Today I'm going to talk a little bit more broadly than our previous speaker Graham into where cannabis may have a role in chronic pain. And we're really here probably for ourselves as clinicians mainly when we deal with patients who make us want to run. When we see our lists and we look at who's on the list and we think, oh no, there's so-and-so with their chronic pain syndrome who's divorced from their wife, got no support systems and going on a very much a downward spiral financially, emotionally, and in every other way. And really it's for patients like, this is Constantine Malupu, and he's given me permission with his wife Jackie and one of their children. And really we're here to help patients like that who basically struggle with everyday life. And I've got a video.
Hi, we are the Mullipoos, and we've been seeing Dr. Kanji for the last almost year, since my husband suffered quite a serious injury over in Australia while he was repairing an industrial roller shutter door. You can see here he suffered traumatic brachial plexus. He also had numerous injuries, serious ones. He's got rods in his back. All of the nerves, or a lot of the nerves are severed from the spine, so he had a lot of pain. We're a New Zealand, Wellington based family, but we've been living in Sydney for the last almost 12 years and decided to move home because obviously we needed the family support with no family over here. And in Sydney, we were unable to have access to cannabis as pain relief.
So it's really people like Constantine who we're here for, and it's not just an individual problem. In fact, when Jackie first came, Constantine had pain 6 to 10 out of 10. His sleep was significantly disturbed, where he was waking a lot during the night. He was having naps during the day, 2 or 3 naps during the day. He was very grumpy, irritable, and quite aggressive at times and angry. And every time Jackie would come in with the child, she'd be in tears and wondering how we can save this family unit. So, she's ready to walk because it's just getting too much for her. So I think it's similar to psychiatric patients, and a lot of our patients, they're not just an island unto themselves, but the whole family in whānau get affected by someone unwell. And this shows his arm. It's severely wasted. And he showed me a picture of when he was doing weights, and he was twice as big as that on his other arm, so he was quite a muscly chap. Now, as I said, I'm going to talk broadly about chronic pain. We are talking about action potentials, electricity, basically in this thalamus, sensory cortex, spinal cord, and periphery. And this is how I explain it to my patients. So, quite simply, and I'm going to go to musculoskeletal pain, which I much rather treat than neuropathic pain. For musculoskeletal pain, I explain to patients that our body is full of washers. We have washers in our knees, in our hips, and in our backs. We have discs, which are washers. Bones generally don't like pressure, and that's why we have all these washers. Once these washers get a little bit worn, if we put biomechanical pressure on them, we basically generate action potentials in the periphery. So if we look at, say, the knee, and how many people in here have knee pain? Quite a few of us. And as we know with our knees, if we sit, our pain might be 0. If we go for a walk, after an hour's walk, it may hurt. If we wear a backpack and walk, it may hurt more. And if we go for a run, we may not last too long. So there's a large biomechanical pattern to that. And this is the same for back pain, neck pain, and other musculoskeletal pain. So that's quite, for me, that's a lot easier to treat. Now, if we take, on the other hand, neuropathic pain, we've got a completely different beast. So for many neuropathic pains, we've got nerves that have been damaged. So his arm has basically been severely damaged. The nerves have been damaged. That feeds back into the spinal cord, dorsal horn, and the sensory cortex, and lots of changes occur. It's not basically a mechanical pattern. Constantine will have pain 24/7, 6 out of 10 plus. It's not like if he can sit down, sit still, his pain will go away. So it's quite a different beast. Whereas, our patients with low back pain might come, they'll lie down and they'll get a bit of respite perhaps sometimes. So I think this is what we're dealing with essentially. And there's a lot of influences on this which I'm going to go into. And the first one's migraine. Migraine is not a headache, and I don't like that definition. It's the genetic predisposition to sensory amplification. And what actually happens with people with migraine, with aura particularly, is the electrical channels in their sensory cortex, in fact, open up much quicker. They produce more action potentials. So, and this is the disparity between what does the scan show us and what does the patient present with. So we often get patients with hardly any pathology for which we have to search an MRI scan to even find it, but they're riddled with pain. And then we get other patients who present basically with bone-on-bone arthritis. And my sister presented recently, my whole family, 3 of us have had problems in this sphere that we present late. And she presented with a slight lump, pretty happy, not really distressed, and said, yeah, I've got a bit of knee pain, a bit of pain in my leg. The x-ray showed bone-on-bone hip OA. She basically had to have a hip replacement. So we've got a spectrum of people. And people with migraine, in fact, have 6.6 times more fibromyalgia, 4 times more complex regional pain syndrome, twice as much back pain, and 3 times as much any musculoskeletal pain. So in my practice of chronic pain patients, I see more people with migraine than people without migraine. Yet the population is around 14%. So having migraine with aura particularly, and I'll go a little bit sidestep. So migraine with aura, who here has had a migraine aura without any headache? Put your hand up. So there's always about maybe 5 to 10% of people. So the migraine aura represents the spontaneous generation of action potentials in the sensory cortex. And usually it's visual, occasionally it's smell, and it's not really just pain. Because that is one of the phenomena for migraine, and you don't have to have a headache with it. But what actually happens is, from the periphery, if someone with migraine had a knee problem the same as mine, and we basically walk the same amount, let's say 100 metres, they're more likely to get action potentials going to their brain than I am. So that's the different spectrums. The next thing was the topic of my PhD, and that was the stress response in the body. And so I looked at, for 5 years, I basically read lots of articles on pain and the stress response. And my interest really was, how does stress amplify pain? And this went back to 1990s, and who here remembers the RSI epidemic? And that epidemic was really interesting because you'd be scratching your head. These patients come in with lots of distress, unable to work, use the computer, and pain in rather weird distributions. And that piqued my interest in how stress amplifies pain. And all the studies for RSI show that there's no pathology to explain it. We do the scans of their arms and scans of their elbows and things, and we can't really find any structural problem within their arms. And even the biopsy studies were negative. So this sort of piqued my interest from, it's probably 25 years ago now. So what happens when we have a stress response is we have 6 neurotransmitters released in the brain, and we recognise these as stress chemicals: serotonin, adrenaline, noradrenaline, corticotrophic releasing hormone, histamine and acetylcholine, a couple in the spinal cord and a few throughout the body. Now in the brain, these attach to receptors, produce second messengers, which open up ion channels. So this is what I learned during the 5 years. And so what we have particularly serotonin and noradrenaline, we have ion channels, receptors rather, in both the thalamus and sensory cortex and spinal cord. So the hypothesis generated was that when we have a stress response, we basically increase the amount of neurotransmitters released. These bind to receptors and produce action potentials, directly increasing our pain experience. And this to me made a lot of sense of what we see. We see people who have chronic pain, they're managing, someone dies, someone leaves, they move house, suddenly they come in, oh geez, it's been just a lot worse than the last week. What have you been doing? Oh, nothing unusual. I know that, I generally don't lift or walk or do things that aggravate my pain, but something's usually happened. Now, the stress response is an interesting thing. The things that increase our stress chemicals in our brain are poor sleep, pain, concentration, and stress. So it's not just stress that gives us our stress response. And for many of you may have heard me speak before, but I'll repeat this. The stress response is designed basically for the tiger in the wild. We see the tiger, the stress chemicals go up in our brain, we run, fight, sweat, and they go down. So we complete the cycle with basically running, fighting, and sweating. Poor sleep, pain, stress, and concentration increase stress chemicals. They stay in our brain and they basically create a sensitization. So they wind up our brain. And this is a real problem because pain produces stress chemicals. Stress chemicals in turn increase our pain, as well as increasing stress-related symptoms of insomnia, anxiety, and depression, and irritability as well. So we've got a bit of a disconnect between our physiological response and our stimulus. The other problem is once we reach chronicity with chronic pain, the cycle I've just explained has gone on for a long time. And so there are a lot of changes that occur for people in chronic pain versus acute pain. Basically, we call this central sensitization. So in our brains, we actually have our descending system, opioid system is one of them, and cannabinoid system would be another, that actually dampen action potentials on parts of our spinal cord and brain. So that's a descending inhibition pain pathway. And so what happens with chronic pain is that descending inhibition reduces. So now when the electricity goes to our brain, the dampeners in our brain are not there to suppress some of it. So one of these is GABA, which we all know if you take diazepam, it basically acts on GABA receptors. And in fact, last July, I was doing research for a new book I'm writing on insomnia, anxiety, depression. And basically, GABA neurons make up 20% of our brains. So 20% of our brain is designed to turn the brain off and reduce basically electricity in the rest of our brain. And in fact, GABA levels are 52% reduced in patients with depression. And they're also reduced in patients with chronic pain syndromes. We have altered opioid binding, and we have brain changes. And this is really fascinating because now there's lots of studies looking at MRI scan measurements of the brain, different parts of the brain. So, in fact, the thalamus is atrophied in patients with chronic pain. The hippocampus also, which is our memory concentration center, pretty much. And the same sort of findings we find with people with chronic stress, with insomnia, anxiety, depression. So it seems likely the sympathetic response unchecked in the HPA axis give rise to changes in the brain that a whole lot of conditions cause: chronic stress, chronic pain, etc. Chronic insomnia as well. We've also got increased sympathetic tone as measured by heart rate variability. And so a lot of these studies are populations of patients with chronic pain and populations of patients without chronic pain. and they basically do the measurements, so they're not just one-off people. And here's a functional MRI scan, and the yellow and red show activation, and the blue shows calmness, reduced electricity. So as we can see in the person with no chronic pain, there's large areas of the brain that are blue, and these aren't present in the chronic pain patient. And there's also a lot more yellow and red going on. So, and this is quite a general talk, and the next talk I give will be on the evidence and all the RCTs on cannabis. But it's important to see where this fits in, really. It's not the panacea for chronic pain. There is no such thing. There might be in the future, who knows, but there isn't at the moment. So when we look at chronic pain syndromes, I think obviously we want to attack the sources of amplification, and so reducing sympathetic tone would be a reasonable start. Therapies, and that's meant to actually read therapists, as well as pharmaceuticals where cannabis fits in. So one of the first things we want to do is reduce sympathetic tone. Now the list in fact has grown as I've been researching this book for 4 years, but basically the things that have been shown in randomized control trials to reduce sympathetic tone include yoga, tai chi, meditation breathing, sauna, and exercise above 50% heart rate maximum. Now let's take it back to the tiger. If we see the tiger, I'll just stroll away and walk quietly. And in fact, the studies show that walking does not reduce sympathetic tone, really. Maybe walk for an hour or so, very rigorous up and down hills might, but generally speaking, when we see the tiger, we generally want to run quickly. And a lot of the studies for depression and chronic pain show that the more you increase the heart rate, the more effective it is. So generally speaking, to reduce sympathetic tone, exercise should be rigorous, enough to make you breathless and your heart race. And that when it does race, that's sort of depleting adrenaline, so to speak. Sauna is one of my favourite things. And heat reduces sympathetic tone. And these things work by biofeedback. And currently I'm working with the engineering school in Auckland University. We're creating a sensor, a small sensor that goes on the finger that measures sympathetic tone through heart rate variability. And we're creating an app on the phone we're going to try and roll this out to every single person in New Zealand on an antidepressant actually. And it's very exciting because what we can do then is measure sympathetic tone, and patients can have this app and they can do something that lowers their heart rate. And if you do this often enough, it'll reduce the stress chemicals in your brain. So how feedback works is when you see the tiger, you're breathing very fast, your heart rate's up. Now, if you reduce your breathing rate, and this has been shown in randomized control trials, and if you breathe 5 or 6 times a minute, your sympathetic tone goes down. If you breathe 12 times a minute, it can go up. So by breathing slowly, you're feeding back to your brain that there's no danger. You can relax. Now heat does the same thing. As we know, as the noradrenaline's released, we get cold hands and cold feet. Who in the room experiences cold hands and cold feet? Put your hand up. Right up. Quite a few of us. That basically is a sympathetic overdrive. It's part of our stress response. And if we then dilate the blood vessels in our hands and feet, it actually feeds back to the brain and reduces our levels of noradrenaline and stress chemicals. That's sort of how it works. So feedback's quite important. There's a recent device that's been made called a Doppel, which some of you may have heard of, but it's a device you put on your wrist and it simulates a slow heartbeat. And basically feeds back to your brain. So it's a really interesting space, actually. It's very, very exciting I've lived in Wellington my whole life, in fact. Born in Wellington, and I went to Wellington Medical School after Otago. But in the last couple of years I've spent in Auckland and working alongside Bruce, and it's been really exciting at the breadth of things going on, especially in the different schools. So there's therapists. Now, as you can imagine, I always say really to patients, I can't really help you. You know, there's very few that I can directly help. But basically I can help you help yourself. And let's face it, half an hour or an hour with me is never going to cut it and never going to help that patient for 10, 20, 30 years. The other thing I'm big on now is I don't really care if my patients are free of chronic pain in 6 weeks or not. My concerns are how they're going to be in 2 or 3 decades' time. We live a lot longer, and the number of people I see with spinal stenosis at the age of 70 now is ridiculous. And every day in my practice I have to say to someone, I can't do anything for you, and no one on the planet can help you. No surgery, nothing. And I say that for good measure, so they don't go looking and go to the surgeon or any other practitioner for that matter. So, with therapists, I believe our space is to understand someone's problem, advise them of what they can and shouldn't do to help their problem long term. 15 minutes to 30 minutes in with a general practitioner is not going to change someone's life, but the correct advice on what a person may or should not do is going to give them long-term help, and same with any practitioner. So, and therapists, unfortunately, if you're dealing with neuropathic pain, which is unremitting, you can't change their positions, biomechanical loading. It's very difficult to, and those patients don't actually get a lot of help from therapists. Support, yes, but I think they come in to reduce their pain. That's what they want. And we come to pharmaceuticals. Pharmaceuticals are a very interesting space, and very misunderstood, I think, actually. On one hand, we've got the researchers and the RCTs, and my interest in cannabis was not from my med school days, but rather Bruce asked me to do a podcast last year. And I don't read systematic reviews and say, oh, okay, that's great, that's given me what I want to know. I'll actually go back and read every article that's ever written on the space that I'm interested in, because it's a real teething job, and this afternoon I'll talk about randomised controlled trials in a general sense as well. So I think really if you're really that interested in a topic, that's the way to approach it, and that's what I enjoy doing. Luckily it's my strength, and so I did that. And so and I don't like believing anybody. I think belief is overrated and expert opinion's overrated. And that's my personal touch. So when patients say, oh, I believe you, I said, I don't really mind if you believe me or choose not to believe me. The proof is in the pudding. When you come back in a month, 6 months, and 3 months, and we'll see how you're going. And if you're not going well, we have to change tack, get another specialist, get another opinion, or try something else. And this is the same with pharmaceuticals. Now, when we look at pharmaceuticals, and I looked at this, so if pain is, and I'll be simple, because I like being really simple actually. I think the jargon cuts out a lot of people. So let's say pain is due to electricity in your brain, simply. Analgesic medication and pain modifying medication reduce electricity in your brain. Lovely and simple way to look at it. And it's not far from the truth actually. So when we look at medications, and I'll go back to a story on beta blockers. On the year that I was born, 1966, someone was having a migraine, and at the same time they were having angina. So they were given a beta blocker infusion. Suddenly, geez, doc, my headache's gone, my migraine's gone. That's the only reason why to the present day we use beta blockers as the #1 preventative medication for migraine. No other reason. That's it. But as we know, beta blockers reduce receptors in our brain, the stress receptors, adrenergic receptors, and that's how it actually works. So if we look at all the medicines, what we find is non-steroidals work at prostaglandin receptors, and this is the reason why during period time women have more pain, because prostaglandins are released, and that's why non-steroidals are sort of slightly better at attacking that space, generally speaking. In opioids, the mu and kappa, cannabinoids, cannabinoid receptors, antidepressants, adrenergic, and if you think back to the stress response and the 6 neurotransmitters that are released, we can see quite a pattern going on here. Antiepileptics also act on ion channels and some on receptors. Antipsychotics, gabapentin, pregabalin, and I'll talk a little bit about amitriptyline. The Cochrane Review states there's no first tier level evidence for amitriptyline whatsoever. We use this medicine on expert belief, perhaps, and for many of us, we know it works. And when you look at, and I'm going to go into the Alberta, Canada synthesis of this soon, and you'll see that it's probably the most effective tablet for chronic pain situations. And think about these tablets. So we use them for epilepsy, for migraine, chronic pain, and psychiatric illness as well, don't we? So it seems to be a theme going on here that we're using these tablets to reduce electricity in perhaps different parts of our brain. But unfortunately, we can't synthesize pharmaceuticals that act on only specific parts of our brain. Hence, we get fatigue and tiredness with amitriptyline. Not because it's a side effect, it's actually just more an unwanted effect, but an effect of the drug per se on a receptor, probably in the reticular formation. Right? So it's a really, I like looking at it like this personally, as you could probably tell. So amitriptyline is called the dirty drug. And I've started looking at this, the more receptors a drug works on, it seems to me the better the effect of that drug. And amitriptyline is obviously the dirtiest drug, although it works on the most receptors and also ion channels. Hence its benefit is probably better than most. And here's the charts Bruce was alluding to previously. And this is out of Alberta, Canada, I think in a general practice setting, Bruce?
I think it's called paincalculator.com.
Paincalculator.com. So what they've done is looked at who's happy after taking medications. And so we find 25% with amitriptyline, 9% with cannabinoids, 13% duloxetine, 18%, 18%, 16%. Now, one of the really interesting things is those figures are pretty low, aren't they?
Those drugs don't work for most people.
And Bruce has just said that most drugs don't work for most people, and he's right.